Hello, Colin Hung here for Healthcare IT Today. And boy, are you in for a treat today. You are about to watch and listen to my interview with Dr. Tim Davis. He is an international pain management specialist with over 20 years of experience in physical medicine, sports medicine, and of course, pain management. He is the founder of Source Healthcare, a client centric, digitally integrated orthopedic and regenerative health and surgery center in Santa Monica and Los Angeles, California. Dr. Davis was a very early adopter of EHRs. In fact, he got started well before meaningful use became a thing. He compared lots of different systems, and over time, he settled on just one that met his high standards. You'll want to stay tuned to learn which one is the one he chose. Oh, and on top of that, Dr. Davis started his own health IT company when he saw a gap that needed to be filled in order to offer his patients a smoother and safer experience. He called the solution BluByrd. And so we're going to talk about that too. So settle in for this extended interview with Dr. Tim Davis. Let's get to it.
Dr. Davis, welcome to the program.
Thank you for having me. Happy to be here.
Yeah, I'm excited. I'm excited to sit down with you today to talk about your healthcare entrepreneurial journey, as well as this amazing product that you've created. But before we do that, Dr. Davis, can you give us a little bit about your background? Tell us a little bit about yourself and about the pain management clinic that you operate.
Yeah, sure. I'll try to be as brief as possible. I went to a 6-year medical program at University of Missouri, Kansas City, in KC, obviously. Started out in general surgery, did a surgical internship down at Ochsner in New Orleans, then did physical medicine rehabilitation at UCLA and the West LA VA out in Los Angeles, and then did a postgraduate year in interventional pain thereafter, and then been in private practice ever since. Some of those situations were kind of shared overhead with other physicians, and then ended up having partial ownership in some surgery centers, partial ownership in a hospital. Through those roles and those ownership positions, I started to learn a lot more about the process of clinic to facility and the communication between clinic and facility. And then around 2015, 16, 17, I started to put pen to paper to just build my own, because I saw so many broken things over those years. And that's where kind of Source Healthcare was born.
Right, so Source Healthcare, that's your clinic, is that correct?
That is correct. Source Healthcare and Source Surgery Center. And so it is a clinic and a surgery center that is essentially in one building, but divided by a wall, two completely separate entities. And so therefore requires different databases to function.
Gotcha. And just so that our audience can know, how big and what areas does Source Healthcare serve?
Oh, so we do interventional pain management, spine surgery, orthopedic surgery, and we have 4 physicians in-house at the clinic, but then we have about 10 other physicians that come from outside of our clinic that bring cases to the surgery center.
So I want to dive into that for just a second, if you don't mind. So what were some of those things, if you don't mind me asking, that sort of pushed you to say, hey, you could do this better and you can solve some of these problems? What were some of those things?
So being involved in a number of different surgery centers, I was on the board of a few of them, and also being involved in a hospital. I saw the breakdown in communication between the clinics and the facilities, because you have numerous practices trying to funnel information into a single location. That single location has to process that information, get the case on the schedule, organize with the patient, et cetera. Also during that time, I started an intraoperative neuromonitoring company where we were supplying neuromonitoring services to spine surgeries and brain surgeries at 35 different locations for 100 different physicians. And so you really started to see the communication breakdown amplified right, at scale. And it was amazing that, in 2008 to 2000, well, we sold it in 2009 to 2020, we were still operating on faxes from clinics to facility surgery centers to hospitals, communication breakdown. And so all that experience led me to think that when I built Source Healthcare and Source Surgery Center under one roof, I thought that proximity of those two entities was actually going to assist with the communication breakdown, and it didn't at all. It was everybody was employed by me at the end of the day, but they started to it was opposing teams. They would point the finger back at each other that, we sent it, no, we didn't get it, you didn't send it, etc. And it was baffling, but I had clarity of it very quickly, that it was just a communication breakdown between databases. It had nothing to do with the people.
What kind of technologies do you use at Source Healthcare in terms of your EHR or other things that help you with this communication challenge that you have?
Yeah, so I'll start by saying that I tried out about 5 different EHRs dating all the way back to 2007 or 8. And I'm gonna say something that might upset some people, but I would say they all suck to a variable degree, right? So and that sounds pretty brash, but the problem is many of these softwares were built for compliance and not built for ease of use. And as time has gone on, they're still functioning on kind of the legacy structure. And so the ease of use they're trying to add on ease of use hereafter, but it's not always successful. So in making the selection to DrChrono, which is what I'm currently on, what I decided on in about 2000, I think back in 2015, maybe about 9, almost 10 years that I've been on it now. I had gone through 5 other systems, plus I had converted to just digital, PDFs and Word documents before that. But they were all very clunky. And a software is supposed to streamline, it's supposed to make things easier. And none of these were making it easier. It was actually more burdensome for my staff. It was easier to get paper charts done than it was to do charts in these other systems. And then I found DrChrono in about 2015. And what really attracted me to them was the ease of use and the customizability of it.
So first of all, congratulations for looking into an HR before meaningful use came on. Because you were looking at these things in 2007. That was before any of the incentive programs were even up and running.
Right.
So that forward thinking of you, congrats. So and you went through that. You went through the whole meaningful use thing, and you went through what I call the EHR Renaissance period, right, where there was like 1,001 EHRs out there, some better than others, and you finally settled on one. And and have you tailored it specifically to your practice, like the surgical centers and so forth? Have you really been able to take DrChrono and tailor it to your use?
Yes. So what was interesting is originally DrChrono wasn't even built for a surgery center, and so I adopted it in my clinic, and I put about 1,000 hours of customization into the system. Now that's not everybody's going to do that, but when I get stuck on a goal, I'll keep going and keep going. And what I saw it as was anything that was a process that needed to be repeated again and again and again. If I could template for that, if I could structure some sort of process within the system that could solve it a single time and then it could be repeated thereafter, it was worth my time. It was worth my energy. It was worth my effort. And so that's kind of the way I looked at every part of the process, every part of the clinical practice. And then when we built out the clinic and the surgery center, I was looking for a system for the surgery center. And once again, they were kind of clunky. I looked at all the big ones and I was like, why can't I just customize DrChrono to do the surgery center?
I do understand from DrChrono that you did run into a big challenge around scheduling, and you did something about that. But can you tell me what that scheduling challenge was that you ran into?
Right. So, being in practice over 20 years and having a procedure-based practice, I was always having to communicate with a facility, whether it be a clinic or, whether it be a surgery center or a hospital. And if you think about that, you have someone sending information from point A to point B. The routine and customary way that that occurs is e-fax, fax, and that was maddening to me because it always resulted in a finger pointing that somebody didn't get it and they didn't check the fax machine, etc. And even at e-fax, it's still sitting in an email box. And so if somebody doesn't check the email box, it's as good as dead. Like if it gets too far down the list off the first page, they just don't see it and they don't know what to look for because it comes through and it is de-identified. It has just this big string of numbers. It doesn't have the patient information or name. You can't look it up by the patient information because it's a PDF. So anyway, you're taking structured data from one database. You are turning that into a PDF. You're sending it over to another database, and then somebody has to do double data entry to go into that database. There's an error rate. Now, we didn't know what that error rate was, but we felt it and we saw it in our own system. So we actually did a study where we got 50 surgical schedulers from Southern California. We gave them 4 surgical scheduling forms, which have about 45 data points on each one of them. Only 8 of those data points are critical, however. It's insurance ID, authorization number, ICD-10 code, CPT code, stated procedure, stated diagnosis, social security number, and then first name, last name. So those are the 8 critical data points that will get you denied either authorization or payment. And so we were making sure to monitor those. So we had them take these 4 sheets and we had them enter them into a simulated EHR database. And then we scored them. We had 2 cohorts, 25 people had 10 minutes perform and another 25 people had 18 minutes perform. And the error rate was 20 to 25%. So that's 1 in 4 to 1 in 5 had at least one critical data error rate, at least one. So that means 1 in 4 to 1 in 5 of your attempted scheduled procedures is not going to make it through. And then it's finding a needle in the haystack as to what went wrong, right? You send it in for authorization, it gets denied. Well, why is that? Well, a 0 became an O, a D became an O, a 7 became a 2, an S became a 5, a 1 became an L. Now, one other thing that we noticed was, 2 other things we noticed. One was the highest error rates occurred with alphanumeric values. The 3 alphanumeric values, insurance ID, authorization number, and ICD-10 code. 3 of the most important pieces of data. And those error rates were up in the 30 to 45% range. Yeah, so the average was 20 to 30%, or 20 to 25%. The other thing that we saw was that when you had 4 digits that were the same, like 4 zeros side by side by side, people would either subtract 1 or add 1. So it would either turn into 3 zeros or 5 zeros. And if you look at any insurance ID, number 1, the majority of them are alphanumeric. And number 2, the majority of them have 4 digits side by side by side. And right there, 2 major problems that cause people to have, a transcription deficit. So in seeing that and understanding not only the impact to the patient care, but also the financial impact, I started looking for something off the shelf, a software off the shelf that would communicate databases. There wasn't anything. There were a lot of companies out there that said they could do it, that they could build it, but then it was very, very expensive to maintain it. And so after investigating this for about 6 or 8 months, I just decided to do it myself. And so we built a software called BluByrd that not only connects the databases, but also organizes all the stakeholders in the surgical scheduling process. Because usually it's a single person in the clinic that does it. And when that person goes out sick, that surgical schedule shuts down.
what are some of the other sort of benefits that this BluByrd software that you've created for yourself has been able to do?
So it's increased overall scheduled events, right? So overall case volume, it's increased. It's decreased cancellations and reschedules, and it's improved revenue because
So
you have a higher kind of batting average, so to speak, of when you see somebody in clinic, you decide that a treatment is necessary that's going to be at the facility. You have a higher percentage of throughput of that actually making it to the schedule and completing that procedure than with any other system that would be out there.
just going to ask that because that was an odd one that stuck out to me. Like in terms of you actually have less cancellations because you have this process. Is that because they're able to get in, they get scheduled, it's on the books, and they're like the patient's committed to this, and therefore there's less chance for them to cancel?
Yeah, well, so think about this. If you go back to that error rate, right,
Mhm.
of the average of 20 to 25%. So you went through the process of getting that patient in the door. You earned their trust. You said, "Hey, I'm going to take care of you. This is what I'm going to do." Now you've done a handoff, and this whole data packet, this patient is sitting there going, "Okay, Dr. Davis is going to take care of me. I trust him." Well, if your system breaks down, if your system is not trustworthy, and it's not the people necessarily, it's the system, because literally no person can do the job of data transcription the way we just described it. When you have a 10-digit alphanumeric value and you say, transcribe it over from here to here, the number of permutations for that single object are into the hundreds of trillions just because it's 10 numbers possibly and 26 letters possibly for each of those cells, right? So it's destined to fail. People can't do that job. So when it is structured data, you need to keep it structured, and you're able to do that effectively and efficiently, get it through to the authorization process. Everybody gets looped in. Coding people get looped in. Billing people get looped in. Any assistant surgeons, any salespeople, any people that do materials management, it all gets looped in. So all those different potential fail points are now consolidated into one kind of hub and spokes and then transferred over to the facility. So right there, you're decreasing that average of 20 to 25% error rate down into the single digits for sure. And that person has a higher probability of actually getting the procedure done, getting it approved, and then in the end, getting it paid too.
Gotcha. I love that. So you're in a way having this builds confidence and trust with the patient, and therefore less like. And then also just the process is so much smoother. You're not getting the denial and all those kinds of things, which delay that potential procedure
Correct.
when you don't have a system like this. I get it. Thank you.
Correct. And one other thing I'll add is patient safety, right? That like we've talked about just process and the business of it and the economics of it, but the patient safety, which is probably the most important thing, first do no harm, that's a done deal. There's zero opportunity for there to be a breakdown of that data transfer from point A to point B. Because look, right side, left side, you don't want to make that mistake. And you don't want to make a mistake where someone doesn't have a pre-op clearance and they have, uncontrolled diabetes, and that somehow didn't get transferred over, and so the anesthesiologist doesn't know about it, et cetera. There are all these kinds of things that come up from a safety perspective, and we tackle that in the same process.
You've essentially engineered and mitigated out a fail point, right? Like you that's from a safety standpoint, that's always what engineers want to do. That's always what we all want to do in healthcare, is eliminate as many of these fail points as we can. You've done it by just doing something very logical, or in terms of just making something electronic that shouldn't be manually transcribed.
Yeah. Yeah. Well, the idea that we're still depending on fax, like that was invented in what, the 40s? or 50s, I think. I think the first fax was around the 40s or 50s. And that is still one of the main forms of communication for healthcare today. That is absurd.
Let me get technical on you for just a second. Does the information that comes in through BluByrd, does that go into DrChrono? Is that
Yes.
the ultimate landing point for this information?
Yeah. So there's APIs, and then there's the FHIR structure of data transfer. And so what we do is we take unique cell to unique cell and mapped out. So there is no opportunity for breakdown. When you're on the receiving side, any of these EHRs, including DrChrono, they will only accept certain structures in certain cells. So yeah, you could attempt to map it wrong, but at the end of the day, there's kind of fail safes on the receiving side a lot of times to where you can't put in a birth date into an authorization number or into an insurance ID number. So we're taking like to like and doing a direct transfer. And the other thing is when you have like an outside consultant, somebody that does a pre-op clearance, they need the whole chart also. So in this data transfer, we are pulling documents. We're pulling the clinical notes. We're pulling the MRI reports. We're pulling all the pertinent information that anybody involved in that case would need to know and need to see and review. And so like a pre-op clearance, they would want to know what's the procedure that's going to be done. What was the finding on the MRI? And so that goes to that pre-op clearance MD. Also DME, durable medical equipment. They need that information so they can do their billing as well. They need the codes. Everybody needs the diagnosis codes. They need the CPT codes. Anybody involved in that procedure needs to have accurate ICD-10s, accurate CPTs, and if there's a mismatch, gets denied. If it's not consistent, here's another example. The clinic gets authorization, right, with good data. Now, during the transfer to the facility, something gets transposed. Let's just say it's a 0 and an O. It's as simple as that. One data field, one character transposed, right? Okay, now case gets performed, right? They had authorization, case gets performed. Well, what billing information is going to be sent out from the facility? The wrong information. Only one transposed number, however. So now what happens is the clinic sends out their professional fee, the facility sends out their facility fee. One gets paid, one gets denied. The one that gets denied, now they're going back to it and they're going, well, why? Well, in the denial, you get a categorical denial. You don't get a denial that says, hey, you were 98% right. Everything was 98% right, but no, they say this member doesn't exist because the insurance ID number is wrong, or this authorization number or ID is not applicable to this case. And you go, well, what part of it? So now you got to do recon. Now you have to have your facility is now trying to contact the clinic. Guess what? The clinic's done. The clinic's done with that case. They don't want to touch it again. So now you have this side talking to this side, and now they're at odds again because they're like, hey, please, come on, give us this information. So it's like that's one of the worst case scenarios because the facility is now out all the money that it took for that case. They have the liability for the implant, for everything, and it's just one set of numbers transposed.
You just made our audience very happy when you mentioned FHIR in this interview. So thank you for that. Yeah. But also you mentioned using APIs. So you're actually using the APIs, and DrChrono has the APIs to allow you to do that integration. That also is something that we don't hear enough about. So congratulations on that.
Yeah, so that's one of the unique things about DrChrono, and there's a few other systems out there that have open APIs, and so the open APIs is kind of the easiest way to just get data cell to data cell, and But what I will say is it really comes down to the EHR's effort towards documentation, right? Because many of these EHRs will go, oh yeah, we have open, we will work with developers, et cetera, et cetera. And I mean, they say that, but do they actually do that? Because when you look at their documentation and things are a little unclear, or you build it according to spec, you build it according to exactly to spec, and then it fails. It doesn't work. And then you got to get one of their people on the phone. They go, oh yeah, we updated that a month ago. And you go, but wouldn't the first thing be to update your documentation? Like, wouldn't that be like one of the first steps you want to do? It makes me a little suspicious that maybe not everybody is that eager to share the information. And it makes it very frustrating for anybody that's building to these connections. But DrChrono Open API, man, it is fantastic. It is fantastic, and it works like a charm. And I wish all the systems were more like that, because at the end of the day, we're trying to provide better care to our patients, and this is a means of doing that.
Just a reverse question then, is DrChrono pretty supportive of BluByrd and of you? Like, it sounds like they were in terms of working with you. Or
yeah, they've been fantastic. I would say that even from the early days, Michael and Daniel, the two founders, I went up there a couple times to their headquarters and met with them in the early stages when I was doing a whole lot of customization, and had a lot of talks with them as we were starting to conceptualize BluByrd and what to do. And then the folks at EverHealth have been amazing. They're the ones that acquired DrChrono. And so I think they're trying to continue forward with a bit of the same mindset of there's got to be ease of use. There has to be ease of use. And part of that ease of use is being able to work with developers, being able to work with people that have good ideas about streamlining the process, data transfer, and some of the processes that may not be completely managed within the EHR, but are absolutely necessary to function in a clinic, right? And I want to say one other thing about DrChrono. Like, I find that if I were to try to describe to somebody EHRs, I mentioned earlier that it was more burdensome to process, actually. And so even when you look at a lot of hospitals, and we all know that about 85% of hospitals have one type of system, and that one type of system requires this entire middle layer of supervision for the users. Like, there's this whole support system built on top of using it appropriately and helping people figure out like just how to navigate the thing. My analogy to that is you are telling a physician or a clinic employee, a hospital employee, here, go into that room that is this massive bank of filing cabinets and do your job. There's zero direction on what to do. You open it up and you look at it and you go, where do I start? Right? My belief is that software should make it easier for people. It should be intuitive. The moment you log into your screen, you should have the first 4 hours of your day, like boom, 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 boom. It should be presented to you. It should be very much like the Tesla auto drive, right? It's like you just program in kind of the things you need to have happen, and it's going to help get you there. And then all you have to do is focus on the tasks that are absolutely necessary from a timeline perspective. What's most urgent? Focus on that. The software should present those things to you. It should help you with those. What are other people in my practice asking me to do? It should present those things to you. And so DrChrono put a whole lot of effort into task management and tasking back and forth and being able to attach things to it. And it's been extremely valuable when we're using DrChrono. But that's also another thing that we focused on with BluByrd, is making sure that the vital parts of the process of scheduling were presented the moment someone logs in.
Dr. Davis, my final question, where can people go to learn more about Source and about BluByrd?
So sourcehealthcare.com. That's our website. You can check us out. The clinic and the surgery center both highlighted there. We do a lot of FDA clinical trials as well. Been a principal investigator on about 20 of those over the years. We do a lot in biologics as well. And then BluByrd.com. That's BluByrd. BluByrd.com. You got to spell it kind of funky for it to be a tech company.
I love it. Well, Dr. Davis, thank you so much. You shared so much great information with us. Appreciate you being on the program today.
Thank you very much for having me, Colin.
Hey, I really want to thank Dr. Davis for taking time out of his very busy schedule to talk with us today about his practice, his experience with EHRs, and about BluByrd, the solution he created to address a challenge he was having. My key takeaway from today's discussion is actually not a topic or a useful tip. It's actually the fact that Dr. Davis was equally comfortable having a conversation in three very different domains. As a physician in the clinical domain, as an entrepreneur and owner in the business domain, and as an IT leader in the technical domain. It's very rare to be able to speak with someone who can switch from talking about APIs and HL7 to broken referral processes and eliminating internal silos so that patients can be treated faster and better. It was a sincere pleasure to talk to Dr. Tim Davis. A quick shout out to the team at DrChrono for introducing us in the first place and helping to arrange this interview. And hey, if you enjoyed this interview, please mash that like button and click subscribe. Also, head on over to healthcareittoday.com where you will find more great content like this. I'm Colin Hung for Healthcare IT Today. Thanks for being here, and I'll catch you on the next video.